होते हैं। अगर आपको ब्लूटूथ पे क्लिक कर देंगे ना डिवाइस से, उस पे दबा चला। ओके, एक मिनट देख लो।
Yeah, the first button, like the microphone. So you click on that, then you can see, like select a microphone, like a speaker, you know.
Yeah. But it shows connected.
Yeah. You click on the arrow.
Audio control.
The arrow next to the audio, and you see their microphone.
It shows connected. Now, if I see the audio control, maybe. There is open sound settings. Okay, I'll see it later on. No problem. Let us not waste time on this. We'll see it later on. So back to the basics.
You can take it, sir.
I'll take it later on.
I take the screenshot and show you.
Okay, no problem. We'll do it later on. Harman is here, so I will not waste time now. Okay. So, no problem. I'll do it tomorrow. No problem. Okay. So, here we are. We are about to begin the third etiological cause, that is the spondylolisthesis. So, in the spondylolisthesis, it is a continuation since in sciatica like pain there is occur also one of the reason of the spondylolisthesis. So in this what happens actually in the spondylolisthesis, it is the forward translation of one vertebra over the lower vertebra. So one vertebra is translated forward above the lower vertebra, right? Sorry. Yeah, Herman, please translate.
Halo, jadi ini adalah sciatica, itu spondylolisthesis.
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 Spondylolisthesis. Yes. That means the forward translation of one vertebra over the lower one.
Oh, jadi ini maksudnya adalah vertebranya agak maju ke depan dibandingkan dengan badan vertebra yang lainnya.
Okay, right. So spondylolisthesis, it is a term in which there is forward shifting of one vertebra over the other. Below vertebra is shift forward over the lower one. As you can see on the picture on the right hand side, that below one is the sacrum and above one is the L5. So with the arrow marked, they have shown that in this direction it has shifted. Usually it remains with the in line with the sacrum, but when the vertebra is shifted forward below the lower one, so that is called as the spondylolisthesis. Arman?
Oke, jadi seperti di gambar kita bisa lihat biasanya kan vertebranya dari L5 1. Tapi karena dalam spondylolisthesis ini vertebranya kan maju ke depan sehingga sambungannya tidak ada. Over.
This all we have seen, all the anatomical part and all the things. So we'll not go into details about the anatomical part. Embryology you need to know for now. So we need to know about the classifications, right? So there are various classifications. Like there is some bony defect which occur by birth in the children. So this is called as the dysplastic. One is the ischemic. So we are usually concerned more with the degenerative, traumatic and the pathologic one. Okay. So these are the main classifications. So we are more deal with the degenerative, traumatic, and the pathological. Yeah, Herman.
Oke, jadi ini adalah klasifikasi dari spondylolisthesis yang yaitu di plastik yang terjadi pada anak-anak, kemudian sistemik yang terjadi pada orang tua, kemudian degeneratif dan traumatik patologik. Yang akan kita bahas adalah degeneratif dan patologik. Over.
So this plastic we are not discussing since it is because of some congenital defects, right? Ischemic also some because of the repetitive, you can say some fracture or some trauma, some biomechanical changes that occur at the L5. So if we see on the X-ray, so here you can see the lytic spondylitis. So actually this occur because of the pars interarticularis, which is the part of the bone, the spine, and in this there are some due to some repetitive movements. Okay, so there is you can say that there is the shift in the bone forward because of the pars interarticularis. Since we are not deal with these patients, so these are basically the surgical cases more of. So we are more concerned with the degenerative part, like in this the shift, the most common is the L5 L4 L5 shifting, right? Most common the forward movement of L5 over the L4 over the L5, right? And this could be occur at any age. So the main reason for here occurring of the spondylolisthesis is it is because of the degenerative. But the main component, if we see and when we observe the patient who came with the degenerative spondylolisthesis, is because of the weakness of abdominal muscles. So it is the abdominal muscles which we have to work specifically on the degenerative spondylolisthesis. Yeah, Herman.
Jadi di antara 4-5 karakteristik dari spondylolitesis ini yang akan kita bahas adalah penyakit degeneratif spondylolitesis.
Okay, Herman, you say only listhesis. That would be sufficient.
Okay.
Listhesis.
Listesis. Oke, jadi ini terjadi karena adanya perubahan degeneratif yang sering terjadi pada bagian lumbar 4 sama lumbar 5 dibandingkan lumbar 5 dan S1. Over.
So here are the certain CT changes that we can see. There is some degeneration around the area of the polaris, and the facets are coming forward into the near to the epidural spaces. And the second most common reason is the traumatic one. Whenever there is any trauma, you can say whenever there is any trauma, any kind of trauma, okay, any kind of trauma that occur in the areas of the body's pedicles or the disc, okay. So that we called it as a traumatic spondylolisthesis. So any trauma, any fracture that occurs around the vertebrae or the spine. So in those cases, we have seen that since after injury, what happens? The stability of the spine that is guided by the various ligaments. On the anterior side, there are longitudinal ligament. On the lateral side, there are lateral longitudinal ligaments. On the posterior, there are posterior longitudinal. So whenever there is occur any injury to the spine, the stability of the spine got reduced. So due to that reason, the traumatic spondylolisthesis occurs. Okay. Yeah, Herman. Herman, please translate.
Oh, I forget. Oke, jadi
It is about the yeah.
Oke, jadi untuk yang traumatik punya ini biasanya terjadi karena adanya luka pada tubuh vertebra maupun pedicles maupun bagian disnya. Bisa terjadi pada area anterior ligamen maupun posterior ligamen maupun lateral ligamen. Jadi ini biasanya terjadi karena trauma benturan ya. Over.
So similar way, the third one is the pathological spondylolisthesis. So in this, day before, someone was asking question about the rheumatoid arthritis, whether the sciatica occur in rheumatoid arthritis also. So this is the main reason, right? So it is more of pathological because of the inflammation around the facets and all these joints of the spine. So they occur the shift in the vertebra, which causes some compression around the nerve, which causes the sciatica-like symptoms. And also the metastasis, any tumor that would be around the spine, that also sometimes compresses the one vertebra over the other vertebra. So that also causes certain pathological changes, which causes the pathological spondylolisthesis. Yeah, Herman.
Oke, sedangkan untuk spondylolisthesis pathological ini biasa terjadi karena patologi dari suatu penyakit tertentu, misalnya ada radang pada bagian tulang belakang yang sering terjadi, misalnya adanya rheumatoid yang pada tulang belakang ataupun adanya tumor metastatis yang menyebabkan penekanan pada tulang vertebra ataupun saraf-saraf yang di dalamnya, sehingga terjadi perubahan pada letak vertebra.
Tell the meaning of metastasis also.
Metastasis itu kayak
any cancer or tumor that is, you can say, not confined into its boundaries, which is spread. The cancer which spread is called as the metastasis.
Already.
Okay. Okay, so there are certain more classification that because of developmental, so we are not more concerned with the developmental part here. So we are more concerned with the traumatic, post-surgical, pathological, degenerative. So all these things, all these cases, we are able to treat with the NIBS and our treatment. So there are certain gradings in this. Like in this, you can see the shift of the one vertebra over the other vertebra. There are certain gradings which are there. So they it is because as it is more common with the change in the postures. So usually sometimes this findings we whenever the patient complains of back pain, when we advise them the x-rays, so we got these findings in the x-rays sometimes, specifically in the adolescent if we see. So this is more common. The L5S1 is usually more common, and there is certain wedging also. If you observe the vertebra, if you observe the L5 vertebra, there is certain wedging. Okay, this wedging is because of the posture changes that occur in them. Okay, and also it may be because of the you can say the lumbosacral kyphosis. Okay, the anterior translation. Yeah, Herman. So these are the clinical things we see in the X-rays. So as you can see on the right side, the X-ray is also there, although it is not clear, but this the picture on the left is the same, which depicts the X-ray findings on the right side.
Oke, jadi ini bisa kita lihat melalui X-ray. Nah, semua kasus yang terjadi pada masalah ini bisa ditreatment dengan menggunakan NIDS. Ada beberapa treatment pada pergeseran tubuh vertebra. Yang sering terjadi itu adalah pada bagian L5 dan S1. Jadi jika kita melakukan observasi pada bagian L5 biasanya akan ada tonjolan. Ini karena masalah postur tubuh. Over.
In the early stages, patient complains of low back pain. The main most common symptom is the low back pain, and when it sometimes you can say become more severe. So when we check the patient, we need to also check these things, like we have to take the history, and we have to check also the most important thing is the hamstring tightness, right? The most important thing in the spondylolisthesis is the hamstring tightness. So when you observe the patient, right? So I'll just demonstrate how to check the hamstring tightness. So when we make patient lie, and we'll ask when, like the same way we do the SLR test that we did discuss day before. So in the similar way, we can check the hamstring tightness, and also we have to see the gait abnormality. That means when we make patient walk, so we will see the certain gait pattern changes. So these are the things that we need to look upon when the patient visits us with the back pain or the radiating pain, and when we suspect, or you can say when we correlate with the x-rays that there is possibility of spondylolisthesis. So that is why knowing the reason is important for the pain which is radiating to the leg. Remember, we started with the sciatica, right? We are covering today one of the reason. What is the cause? What is the root cause? So that is why in each case our treatment would vary. In each case our treatment would be different, right? So this is the one of the you can say etiology, cause. So according to that we have to do our treatment. Yeah, Herman.
Oke, jadi simptom yang paling kelihatan adalah nyeri pada tulang belakang. Nah, selain itu kita harus mengecek
Just
halo ya, yes.
give me.
Oke, saya terjemahkan dulu. Kita juga harus mengecek histori pasien. Kemudian bisa mengecek hamstringnya, apakah hamstringnya ada tegang atau hamstring adalah pasien disuruh tiduran, lalu kita cek ketegangannya. Kata Mr. Lahul udah pernah dibahas ya, cek hamstring. Selain itu juga kita harus mengecek cara jalan si pasien, cek patternnya. Dengan demikian kita baru bisa mengetahui apa sih yang menyebabkan pasien mengeluhkan sakit atau nyerinya. Apakah itu karena sciatica, dan sciaticanya itu sciatica yang jenis apa? Over.
Thank you. So we have to look all these things about the nerve root compressions which are coming because of the spondylolisthesis. Also we have to check the hamstring tightness, and also we have to see the gait pattern of the patient so that we can check out about the tightness in the certain muscle when patient walks, right? And also in the degenerative cases there could be spinal claudication. That means the claudication that we have done yesterday in the stenosis part. So it is sometimes combined with the claudication in the degenerative cases. Okay. So in each of these cases our treatment would vary. Okay, in each of these cases our treatment would vary. So here it is. You can see the sciatica crisis typically seen in high grade adolescent. Okay, so this is spondylolisthesis, as you can see. So this is the most common posture, right, in case of the spondylolisthesis, severe you can say grade of the spondylolisthesis, right? As you can see, this boy is standing, and if you observe at the hamstring level, right, the hamstring muscle, back of the thigh, you can see there is severe tightness. He cannot make his legs straight. So why he is standing with the back bent legs? It is because of the tightness of the hamstring muscle. So hamstring muscles are tight in this, and also the iliopsoas, right? The hamstring and the iliopsoas both are tight in this, right? And patient would have the sign and symptoms that the signs would include the sciatica-like pain. So patient would have sciatica-like pain in his legs. Okay, and if you observe the pelvis, it is slightly shifting forward. It is slightly shifting, but I'll just demonstrate. Just observe this picture in your mind. Okay, just observe the picture in the mind, and then I'll demonstrate you with bones what are the changes they are there in the body. Okay, and the sacrum is into the vertical position. There is no kyphosis of sacrum. Sacrum goes into the vertical position. Okay, so these are all the changes that we have to observe, right? Now you can see the lower back. So there is some more, it is more round, right? It is more round. So that means there is hyperlordosis in the lumbar region. There is hyperlordosis in the lumbar region. Okay, there would be tight hamstring. There would be sciatica-like pain. Sacrum becomes straight, and pelvis also moves slightly forward. Okay, when this type of patient walk, they walk with the waddling gait like a duck. So these are the signs which we see in the spondylolisthesis patient that we called as Fallon-Dixon sign. Yeah. Please translate.
Oke. Jadi untuk kasus spondylolisthesis ini kita bisa lihat ya, salah satu cirinya seperti cara berdiri dari orang ini. Nah, ini yang disebut dengan Fallon-Dixon sign. Jadi ciri-cirinya adalah nyeri ringan pada pinggang atau nyeri ringan sciatica, kemudian iliopsoas dan hamstringnya tegang. Kita bisa lihat dia cara berdirinya, kakinya tidak lurus, kemudian juga pelvisnya juga condong ke belakang. Pelvis yang di pantat itu kita lihat dia agak ke belakang. Kemudian sakumnya juga dia ke posisi vertikal. Kemudian pinggang bawahnya juga agak melengkung. Jadi dan ketika dia berjalan seperti bebek.
Over. Thank you. Can somebody please take the picture and put it in the group? So since this is very important, just by observing this picture and the you can say the things which are written on the left hand side, you will be able to treat spondylolisthesis patient using NIBS. Just by observing this picture. Everything is written here. Just we have to observe what are the things we need to treat, and we can use it and treat with the NIBS. And this patient can be recovered wonderfully in just few settings. Done. Shall we move forward?
Yes.
Okay. Now, what could be the reason of the back pain? So, in the spondylolisthesis, it is also combined with the back pain. So, there could be many factors which also plays. Since when the spine shift forward over the lower vertebra, so there would be the possible reason for pain could be it is because of disc degeneration, it is because of facet, it could be because of chronic nerve root irritation, and patient may also accompany spinal stenosis. So what it does mean? It means that we have to treat everything around these areas. We have to treat everything around these areas, right? So disc, facet, chronic nerve root irritation, and also the spinal stenosis. So these may be accompanied pain, may be due to any of the reasons out of these four followings. So what we see in the radiography. So here you can see, in this film you can see one vertebra is shifting slightly forward over the other vertebra. That means the most common one is the L4. If you observe, that straight one is the sacrum, and on the left hand side of the picture, left radiograph. So and then you see the L5, and if you observe the L4, L4 is shifted forward over the L5 vertebra. L4 is shifted forward over the L5 vertebra. So that means there is L4, L5 spondylolisthesis. So whenever there is a shifting of the vertebra over the lower vertebra, so then it is more likely to happen the disc will go into the degeneration. Okay, since as you know that now that in between the two vertebral bodies there is a disc. If this disc is if this upper spine, L4 spine, is shifted forward, then there would be more compression on the disc, and it is more likely with the, you can say, movement and all the things patient would do, the disc would more likely go into degeneration, and this also sometimes causes the compression of the nerves, and that creates the sciatica like symptoms. Okay, is this clear?
Dr. Raul,
Yes, sir.
can I ask a question?
Yes, sir.
Yeah, what causes the shift of the sacral bone?
What causes
The shift.
shift of the bone? Okay, there are many possible reasons. As we have discussed in the last slide, if you observe this slide, so what happened is, in this there is a tightness of the hamstring muscle. Okay, so due to the tightness of hamstring muscle, there is shift in the curve of the spinal curvatures, and also the iliopsoas is tight. So that means this boy is not able to stand in the erect position. So due to the tightness of the hamstring muscle and also the iliopsoas muscle, there would be shift in the curvature of the spine. Now, when the abdominals are weak, it will create further space to move the vertebra forward. This, you can say, makes the a certain situation. This makes a certain situation in which it creates a certain situation in which that vertebra has to move forward, right? So it is like that when 10 people are standing and they 9 people will push them behind, then the person who is standing in front of the line, they, that person would likely have to be shifted forward. When the 9 people are shifting forward from behind, then the person standing in the front has to be moved forward, right? So it is like that. So it creates a situation here, like hamstring are getting tight, iliopsoas is tight, and the posture is getting curvature more, and the sacrum is straight, and now when the abdominals are weak, so it makes the shift of the vertebra forward, like that.
Thank you.
Okay, sir. And even if not all these factors are present, even if not all these factors are present, even 1 or 2 and 3 factors would be there, then also it would be sometimes happen. Like those who have the very weak abdominal muscles, in those cases also this would happen.
Okay, thank you.
Right, sir. Yeah, Harman, please translate for this X-ray.
Oke, untuk spondylolisthesis ini dia bisa nyeri bisa dikarenakan oleh degenerasi disc, bisa karena degenerasi fasciit. Jadi dalam hal ini kita obati semuanya, termasuk nerve root, termasuk juga spondylolisthesisnya. Kemudian pada gambar ini kita bisa lihat di bagian L4 dan L5. Jadi kita bisa lihat bahwa L4 dia bergeser ke depan. Ke depan itu dia agak condong ke daerah perut. Nah, dalam hal ini kita harus treat area semua ini, yaitu L4, L5, L1. Nah, ini pergeseran ini bisa disebabkan karena penyakit degenerasi pada disc ataupun pada tubuh vertebra, dan juga bisa menyebabkan kompresi saraf sehingga menyebabkan simptom ringan sciatica. Jadi tadi ada pertanyaan, apa sih yang menyebabkan tulang bergeser atau pergeseran tulang? Ini bisa disebabkan karena ketegangan pada hamstring maupun iliasoas, sehingga tulang belakang kita akan bergeser ke depan. Apalagi ketika otot perut ini lemah akan menciptakan ruangan. Jadi ruangan itu mendukung ya tubuh vertebra.
அச்சிக்கா கூப்பிடுங்கள. What the mic, please?
Thank you, sir. So here you can see the radiological examination. Two things that we have to see. Actually, this is for measuring the angle, right? Although in clinical things we can just by observing the shift, we can observe the shift or the change in the angle, right? But for those who for the orthopedic one, they require the exact angles so that they should decide whether it's it could be treated conservatively or it require the surgery, because sometimes when the shift is much more forward, then it would be the surgical case. So there is the two things that we have to see in this. That is, first one is the amount of displacement, how much there is the displacement, right? Like if you say in the last one x-ray, like in this way, if you say, so there would be around you can say 25% displacement, right? There would be 25% of displacement. We are talking of percentage, although it can be taken in centimeters also or millimeters also. But for our understanding, let us say there is 25% shifting of the vertebra. So if it could be around 50% or 60%, that we can treat it very easily with the NIBS and all the things. Although the complex cases, those who have complete shift, that also sir has treated. But for us, we can treat up to the 50% comfortably. Okay, so 50% shifting, we can treat them comfortably with the NIBS and all these treatments. Yeah, Harman.
Okay. Kita bisa memperhatikan pada gambar itu adalah radiologi pada bagian lumbar. Biasanya ada rumus dalam perhitungannya. Ini digunakan oleh pada radiologi. Jadi biasanya pengukuran rumus seperti ini untuk menentukan beratnya suatu penyakit. Misalnya pergeserannya, apakah pergeserannya jauh atau enggak. Jadi dengan menentukan sudut pergeseran ini, maka seorang radiolog baru bisa memutuskan apakah penanganan ini bisa dilakukan secara konservatif atau harus dilakukan dengan pembedahan. Tapi kalau dalam sudut pandang kita bisa kira-kira menggunakan persentase ya pergeserannya. Pada gambar itu kita bisa lihat itu kira-kira 25%. Jadi dengan menggunakan metode NIBS kita bisa melakukan treatment untuk kasus pergeseran tulang belakang atau tubuh vertebra ini sampai 50%. Maksud saya kalau beratnya 50% masih bisa di-treat dengan NIBS.
Thank you. Now, if we want to measure the exact percentage, so there is a method for measuring the exact percentage. That means you have to find the X and Y here. Okay, X is around the you can say we have to start from the L5 vertebra in this case and until the this line which joins the upper border of the sacrum. So that is the X line and Y line. So you have to find the X and Y. So there is formula for knowing the exact percentage of the slip. So X divided by Y into the 100. So that would be the exact amount of percentage that you can find out how much percentage of the displacement is present. Okay, and there is also method of measuring the slip angle. Okay, so we have to mark the anterior border of the upper vertebra with the lower border of the uh, other vertebra, and then whatever angle it is formed, like B here, it is the angle. So this is the angle which we can measure for the spondylolisthesis in the radiological examination. Yeah, Harman?
Jadi kita bisa melakukan perhitungan persentase dari pergeseran tulang. Misalnya yang vertikal itu adalah X, sedangkan yang horizontal itu adalah Y. Jadi X bagi Y kali 100%. Nah, dari situ kita bisa menentukan persentase pergeseran tulang belakangnya, seperti di gambar ya. Kemudian untuk mengukur sudut kemiringan atau sudut pergeseran, kita bisa membuat garis seperti pada gambar. Over.
Rahul.
Yes, ma'am.
I ask the X and Y, the angle is on just in the X-ray. We have to look for it in the clinical.
Yes, in the X-ray we can, with the help of X-ray we can find out.
So if the patient that doesn't have the X-ray, so we have to observe with on eyes. So,
actually, we require X-ray. X-ray is must in this case if we want to find out the spondylolisthesis. Although we can find out clinically also. In the clinical, when we palpate the area of the back of the patient, and when we press the spine, so there would be step deformity. So maybe in this slides, if it is there, I will just show you. So there would be the step deformity. So like in this X-ray, we will see that there are certain displacements, right? So if there is 25% displacement, that we call it as grade 1. If there is 2, that we call it as 25 to 50%. And if it is grade 3, 50 to 75%. So until between grade 2 and grade 3 we can treat, right? But not for the grade 4 and 5. It is only sir who treats, although the 4 and 5 would be the surgical cases. So 3 is also, you can say, the severe one. 1 and 2 we can treat it easily, right? Yeah, Harman, please translate.
Jadi pada gambar ini kita bisa melihat grading dari spondylolisthesis, yaitu pada gambar pertama yang adalah gambar normal, kemudian yang kedua adalah grade 1. Grade 1 itu apabila pergeserannya di bawah 25%, sedangkan grade 2 apabila pergeserannya 25-50%, grade 3 adalah 50-75%, dan seterusnya. Kalau untuk kasus grade 1, 2, dan 3, kita masih bisa melakukan treatment, tapi di atas grade 3 itu hanya saya yang bisa lakukan. Over.
So through the MRI also we can find out. Now we come to the management part. And we do our own management. So we can stop sharing the slide, or we could go back to the this way. Yes. So here you can see how we have to treat the spondylolisthesis. Like suppose we have find out the clinical things and also correlated the things with the X-rays, that this is the case of spondylolisthesis, right? Now, first thing what we do here is we'll treat the larger group of muscles, which includes the hamstring, iliopsoas, and also we have to treat the back in the same way we have treated for the sciatica, or you can say the disc bulge or the stenosis, right? So in the same way, because in this like we have treated the stenosis one, right? We have to similar way we have to put needles 1 finger distance, and then we have to needle around those area like the nerve root stimulation we did. Okay, in the similar way, we will not put in the center one, the spine one, right? In this case, we will not put the center needles. That means the intervertebral disc one. Okay, we'll put only the side needles, right? So this is the first thing we do. After treating this, after doing the first step, then we come to the second step. In the second step, we have to treat the hamstring muscle. Hamstring muscles, local points, motor point of the hamstring muscles. Okay. First thing is the nerve root stimulation, and then we'll do the second part. In the second part, we have to treat the local muscles. What we will do is we'll relieve the hamstring muscle by needling the motor points. Okay. If you give me time, I'll just tell you about the exact location of the motor points. Yeah, Harman, please translate. Meanwhile, I'll find you the exact location for motor.
Oke. Jadi ini kita akan membahas treatment. Treatment yang kita lakukan pertama-tama adalah treatment pada bagian tubuh belakang atau punggung. Treatmentnya seperti treatment pada kasus nephrot, yaitu subluxation lateral dari spine prosthesis. Kemudian, tapi di sini kita tidak meletakkan jarum di space atau ruang intervertebra ya. Kita tidak letakkan jarum di tengah-tengah. Kita tidak letakkan, kita hanya letakkan jarum di nephrotnya saja. Kemudian treatment kedua adalah lakukan treatment pada otot lokal, yaitu pada otot hamstring, motor point pada otot.
Okay, firstly, we have to do the nerve root stimulation. Okay, after doing the nerve root stimulation, we have to treat the local points for the muscles, and those are basically we will start with the hamstring muscle. So it is usually must whenever there is listhesis, you will find the hamstring tightness. Okay, you will find the hamstring tightness. So in those cases, we have to treat the hamstring muscle at the local areas, and also we have to treat the iliopsoas. Okay. So for the hamstring, we have to treat the motor points of the hamstring. Just give me a minute. Until now, any questions so far, please tell.
Dr. Rahul, may I ask?
Yes, ma'am.
When we do the nerve root stimulation, do we stimulate all along the lumbar region on both sides?
Yes, ma'am. All along the lumbar region, L1, L2, L3, L4, all these things we have to need, right?
S1 as well?
S1, no, S1 is not required.
Okay, thank you.
Any more questions? Any questions?
Sir, may I share the question, sir?
Yes.
No.
Yes, sir.
Sir,
So for the iliopsoas, okay, we have to use the acupuncture point, that is GB27, right? GB27 is the acupuncture point for the psoas muscle, iliopsoas both, right? GB27, right? GB27.
Dr. Rao, it should be
Yes,
should be UB, right? Not GB.
No, it is GB.
GB
It is,
tension.
yes, for iliopsoas. We are talking of iliopsoas.
Oh, okay.
For iliopsoas, it is GB 27, right?
Doctor, this iliopsoas means the abdominal muscles, isn't it?
No. It is the hip muscle, hip flexor muscle.
Oh, hip flexor. Okay.
Yeah. And actually, I didn't exactly remember the point for the hamstring, but I can tell you about the exact location, how to do for that. Since I'm trying to find the acupuncture point that correlates the hamstring muscle, right? So it would be around UB37. Okay, UB37 is the one point for the hamstring.
Dr. Rami, excuse me, your voice is
UB37. UB37. Okay.
Doctor,
Yes.
Murugaya,
Yes, sir.
first you told UB 27, I think.
First one is
GB 27.
at the point of the ASIS. If you see the point of the ASIS, so at this point it is a GB27 point, which is for the iliopsoas muscle.
Sorry.
Okay. The
Okay.
first point is this.
Okay.
Okay, that will be for the iliopsoas. The next one we have to treat the hamstring muscle. Okay, this hamstring muscle.
Yeah.
For the hamstring muscle, what we do it in the clinically will like if this is the hamstring muscle, we'll divide the hamstring muscle into two. Okay, we divide the hamstring muscle into two. We mark from here to here, like from the you can say lower gluteal crease. So here is the gluteal crease.
Yeah.
Here is the gluteal crease. Okay.
Yes.
So we'll put one thumb at the gluteal crease and one finger at the popliteal fossa. Right?
Lower.
Yeah, and we divide this into two.
Yeah.
Okay. So once we divide it into two, this would be the center point.
Thank you.
So from just wait, let me complete. So from here we have to go two zone in and one zone up. Similar way, from here we have to go two zone in and one zone down. We'll get 4 points like this. Okay.
Right.
So these points would be around the UB37. So these 4 points we have to needle for the hamstring muscles. So these are for the hamstring muscles. Yes.
Thank you.
Okay. So please repeat. Demonstrate the point for the hamstring muscle. Yeah, I am repeating. So firstly, we have to we have to put our one thumb in the lower gluteal crease. Okay, this is the gluteal crease. One thumb is at the or you can say one finger at the lower in the popliteal fossa, right? Then we'll divide this area into two. We'll divide this area. We'll divide gluteal into two. So we'll find the one center point. From here you have to go two zone in, one zone up. Again two zone in, one zone down. Similar way, two zone left, two zone out and one zone up. Similar way, two zone out, one zone down. So we'll find 4 points. So all these 4 points are for the hamstring muscles. Okay. So here what we have to do is we have to put the needles and we have to stimulate.
Thank you. Only local points, no?
Yes, this is for the local point.
Yeah. Thank you.
So we'll put these two needles. We'll hold one and stimulate the other. Similarly, we'll put at lower place. We'll hold the one and stimulate the other. Okay. Clear?
Yeah. This fine.
Yes.
Sir, needle size.
It may depend on the girth. From 1.5 to 3 inch it may require.
Okay, sir.
Okay, it depends on the girth of the thigh. 1.5 inch to 3 inch.
Needle in oblique direction.
It will go perpendicular, straight. Okay.
Dr. Rahul, how about GB27?
Yes, GB27. Here we have to put on the ASIS. Okay, 2 needles we can put at this level, and one we have to hold, another we have to stimulate. It will go oblique. Okay, it will not go perpendicular. It will go oblique in this way. It will go oblique, right? So 2 needles will put this. One needle we will hold, and one will stimulate.
Two in the same spot.
Yes, it will go obliquely downward.
So 2 needle is the same place, same point.
Yes, same.
Sir, what are that use
What are
motor pen?
Yeah, these are the motor. See, these are so effective. Even if you do not stimulate, they work very well. Okay. Even if we do not stimulate these points, they work very well. Since you reach near the motor area, since it relaxes whole of the muscle. Okay, and this we have to after stimulation we have to hold this needle for 10 to 15 minutes. 10 to 15 minutes, needle would retain it in position, right? Okay. Yeah, question will take on later on. Just let me complete the process first. Okay. Yeah. Sorry for your cooperation. Thank you for your cooperation and sorry for. Okay. So 3 things we have to do. One is the nerve root stimulation. That we'll do it like this. Okay, we'll not put in the center here needle. We have to put on the L1, 2, 3, 4, 5, L1, 2, 3, 4, 5. All the 5 levels. We have to put needle and stimulate, similar way at all the 5 levels, right? So after doing this, we have to do the hamstring one, the local motor point, and also the this iliopsoas, right? Now 2 things are over. After this, we have to take the brain stimulation. We have to go for the brain stimulation. So in the brain stimulation, we can cover the abdominals also, and also the hamstring and the iliopsoas. So we have to cover certain core muscles, including the anterior abdominal wall muscles. Along with this, we have to include the hamstring and the iliopsoas, right? So for the so here would be the line approximation. Okay, so it is actually slightly below. So this would be the approximate line. This would be the holographic of the body. For those who are new, I am repeating. So this is the holographic of the body. So what you have to do is you have to take one and a half finger from the lower wrist crease. So it would slightly come down. So it will come at this level, right? So from here, you have to take one and a half finger and you have to mark a line, and this line is on the forehead at the level of the anterior hairline. So this anterior hairline, and then you have to place your hand like this. Okay, and this middle finger would be in the center, corresponds the nose. This middle finger would be in the center, corresponds the nose. Then you have to put the hand like this. Okay, so this would come at the anterior hairline. That would be 4 zone from the eyebrows. 3 zone, sorry, 4 finger. That means the 3 zone. When you place 4 finger, that means this is the anterior hairline. So from here you have to palm at the anterior hairline, and then you have to spread the finger. So this would be the spine area. That means this is cervical, This is thoracic, this would be the lumbar, and this would be the sacrum and coccyx. And these two are the lower limbs. The thumb and the little finger are the lower limbs, and index and the ring finger are the upper limbs. Index and the ring finger are the upper limbs, and that would be the spine. Okay, so this would be the back area. This composed of all the back area of the spine. Okay, so now as we have done the core muscles, so firstly we will treat the external oblique in this. That means the direction would be like this. Okay, the external oblique, since the spine is in the center, so this is the spine, so we have to put external oblique 2 needles in this direction. Okay, and then we have to treat for the inguinal canal, the inguinal ligament. Just go down and go slightly oblique here. So this would be for the inguinal ligament. And then for the transverse abdominis, we'll go perpendicular needling, and then we'll go for the internal oblique needling towards the upside. Okay, so this would be inguinal ligament, this would be external oblique, this would be transverse abdominis, and this would be the internal obliques. Okay, so in this all of the abdominal muscles have been covered. Rectus sheath is also required. If we require rectus sheath, then we have to needle it more towards the center one. Like the abdominal one, rectus abdominis, we have to needle more towards the center. More towards the center. Right? More towards the center. Okay. So this we have already done. This was the overview for core muscles, and those who are new, don't worry. We'll keep on repeating these as in the future classes. For just now, you just take the idea. Okay, so after stimulating the abdominal muscles with the brain stimulation, we have to come to the hamstring muscles. So for treating the hamstring muscle, we have to treat the oblique. We have to go oblique. Okay, so if this is hip, this is the gluteal area, this is hip. So firstly, we have to treat the gluteal. Always take the gluteal first. When you take these type of cases, always treat the gluteal first. So this will relieve lot of tightness in the hamstring muscle. Then go to treat the hamstring muscle. So this would be hip. So hamstring would come here. So we have to treat oblique way for the hamstring. We have to treat oblique way for the hamstring. So this, remember, this is for the brain stimulation part which we are discussing now. This is for the brain stimulation part. That means on this area on the head you have to put the needle and you have to stimulate. Okay, so around this area you have to put, and this needle will go oblique. This is also go oblique. So 2 oblique needles. You have to insert, stimulate, and see the change. Insert, stimulate, and see the change. So then we go for the iliopsoas. So iliopsoas will come here, straight, AP iliopsoas. So this will go for the iliopsoas, this will go for the gluteal, and this will go for the hamstring. Okay. All right. Any doubt in this? Is this clear? Now you can ask your question.
So can you
Doctor,
go ahead
who
and
will
for a screenshot, please?
Screenshots of hand.
Okay.
Thank you, sir.
Yes, now you can ask your questions.
Excuse me, sir.
Yes, ma'am.
From Nigeria, Naomi.
Yes, ma'am.
Now, is it on the first phalange of the small finger?
Yeah, if you are treating on this side, we have to do it on both sides. In listhesis, we have to do it on both sides, right? So it is both sides, the little finger as well as the thumb. Similar. The location is here, right? But demonstration is here.
Yes, sir.
Yeah.
Yes, sir. Okay. Thank you, sir.
Yes, question please.
May I ask one question?
Yes, sir. Yes. We'll take 5-10 minutes more. Since I have to have some work, so we'll take 5-10 minutes more. Rest questions we'll take on Monday. Tomorrow we have a class. Yeah.
Dr. Rahul, for psoriasis, the needling is oblique.
For what, ma'am?
Psoriasis.
Iliopsoas. Yeah, it is AP, ma'am. AP. It is straight.
Oh, AP.
Yeah, it goes straight. AP. Yes.
Okay.
For iliopsoas, we have to needle AP. Okay. Or those who are not using needles, they can use the stimulator at these locations. Okay. You have to put one finger and you have to hold with the stimulator. Also try to put the stimulator in the similar direction which we are putting the needles. So this will give you more better results, right? Like when we are using for this, try to tilt the stimulator and hold it in this position. Try to tilt the stimulator, hold it in this, right? Okay.
Sir,
it is
sir,
it is both sides, sir.
Both sides, yes. Both sides, yes. Both sides, yes.
Thank you. Thank you.
sir, I was disconnected.
Yeah,
to
sir.
internet.
Yes.
Sir, the case was the patient get severe pressure by the messenger at the low back region.
Okay. Severe pain in the
That-
low back region.
Yes.
Okay.
That creates a lot of pain, and it goes up to the lolly.
Okay. The pain goes up to the lower limb.
Yes.
Okay.
During masses, it creates a sound and creates a lot of pain during this pressure.
Pressure. Okay. Where where is the pain while pressure?
It is low back
Low back.
pain,
Okay. Low back.
and it radiates up to the
Yeah.
lower
Yes.
limb.
Yes.
Is this the same case, sir, you are discussing?
No. Without X-ray, we cannot
Uh,
say about the listhesis part. Okay. So for the listhesis,
we have to X-ray.
need to know the X-ray. Yes. We need to know the X-ray.
Okay.
So get the X-ray done, and then we can discuss about the listhesis if it is there, and if there is, it is because of the disc bulge and all that we can discuss, right? Okay. So don't worry.
So
We'll
X
take
will be
on.
APV.
Yeah. It would be AP and lateral both. Mainly the lateral view which is required. If it is not able to pay, ask them to do the lateral view of LS spine. Okay. So it is mainly the lateral view that is required, the lateral view of LS spine. Okay. So we'll take on case discussions of all these cases which you want. Since firstly we need to know what we have to do in what type of case, right? Firstly, we have to know what to do in which type of case, although the symptom would remain same. Symptom is same in every case. In stenosis it is same, in disc bulge it is same, in listhesis is also same. But we should first know the root cause, and we should know which tool to use when in which case. Like now we are talking of these hamstring and all this. So if we do this in the acute phase of sciatica, it will aggravate the pain, right? So we have to see which tool we have to use when. Okay. So it's like a car driving initially. Okay, don't worry if you do not get, but it's like a car driving. So you have to know, firstly, you have to know all the tools, like which is gearbox, which is clutch, which is race, which is brake, which is handle, right? So we are now we are going with the familiar with all the tools. So firstly, you should know the tools, only then you know how to drive. Okay. So firstly, just don't worry if you do not get confused. Just know what tools we should have, okay, and how to use those tools. So right now we are discussing that part only, okay. So don't worry about the driving initially. Driving will come later, right? Okay, more questions?
Sir, can I request you something? Can you please show the gluteal location of thumb?
Yeah.
Because the hamstring.
Gluteal location of thumb region, no? Right. So this is the gluteal region. This is all the gluteal region. This is all gluteal region. Okay.
Inner eminence.
Yes, sir.
Yes.
Yes, sir.
Inner. Here the hypothalamus. Here the hypothalamus.
Yes.
Yeah. Any more questions? Okay.
Shall we use the same technique for recovery of the glute muscle hamstring and
No, it totally depends on the case. There is no fixed protocol for any type of thing. Even with these, also we require a lot of changes when we actually have the listhesis patient, right? So we need to assess them thoroughly, and according to their problem, we need to work, right? So there is no fixed protocol or fixed points for any type of disease and any type of person, right? So it actually the problem varies in say like if we take the example of spondylolisthesis. So you will not find same. These are the major things that we will find, but apart from these things there would be certain other things also, right? So we need to take them as a whole, and we need to assess them, and then we have to treat. That we'll see more in detail with the when we do the compensatory patterns, right? So when we see the compensatory pattern, we'll see more details how to look the patient, like in this case we have seen in this case of the boy, right? So in this case picture, if you see there, it is not only this part which is involved. So after treating all these things, we will get 50% recovery, but rest of 50% is somewhere else. That also needs to be treated. Okay, but firstly we should get at least 50%. That is our first thing, right? Okay. Yeah, more question please.
I ask? Okay, thank you. Okay. So for spastic muscle, can we treat by NIT test only or with
Yes.
NIT?
Yes, we can. If we combine both, if you can do the SNIT, then it is the you can say very good option. It is the best thing. And if we do not use SNIT, even though we can treat, right? Even though without using the SNIT, we can recover the patient's spasticity. Okay.
The treatment same with we treat weak muscles.
No, in the spasticity, we have to work on smaller muscles. Okay.
Thank you.
Yes. We'll cover in the further classes. Don't worry. We'll cover. Okay. This spasticity is because of the small muscles that are not working. So if we recover them, then spasticity will get reduced, and we can make by strengthening the larger muscle later on when the spasticity reduced, to make the hand or the leg functional.
Thank you, sir.
Okay. Good afternoon, sir. I have a question, sir.
Yes.
Yes, sir. My name is Bashir from Nigeria.
Okay.
Please, what is the relationship between sciatica and thesis?
Yes.
Is there any relationship between sciatica and thesis?
Yes.
Okay, sir.
Yeah, I'll demonstrate it to you with the help of X-ray, right? So
Okay, sir.
when you see the X-ray here in the radiographic
Okay.
view,
Okay, sir.
So if you see the X-ray on the left hand side, that there is shift of L4 vertebra over the L5, right? Would you able to correlate this? Are you able to correlate this? There is L4 shift of vertebra over the L5. Are you able to get this? Okay. So now what happen whenever there is a shift, right? Since disc is between the two vertebrae, right? That means it is between the bodies of the L4 and L5, right? So whenever there is the shift, then the location of the disc would also get shift, and there, due to the wear and tear, there occurs the degeneration in the disc part. Okay. So due to the disc degeneration, there occurs the sciatica, the nerve root compression. Okay. Got it?
Okay, good. Thank you, sir.
Okay, it would be more clearer with this. So when we have a disc in between this, now what happens when the upper vertebra shifts forward?
Yes.
Okay. So this shift forward. Now, whenever the person does his work, there would be more compression on the disc bulge. Although disc bulge is a shock absorber in between the spine, right? So they act as this, right? Whenever they do the movement, they act within the boundary of the disc. But when they move forward, when it shifts forward, when at that time when the person does the movement, it causes the wear and tear. So it also may tear the ligaments, that means the posterior longitudinal, lateral longitudinal, because of the excessive movement. Although this doesn't allow much movement, right? So since there is a shift, it doesn't allow much movement because of all the ligaments are already stretched, right? Now when the ligaments are already stretched, so whenever there occur any excessive movement, it causes the ligaments to tear out, and it makes the disc shift posteriorly. That causes the nerve root compression and the disc compression. So that causes.
Thank you, sir. Thank you, sir.
Cause of lithosis.
Okay. Thank you, sir.
Okay. Yes.
Good evening, sir. Good evening, sir.
So lithosis is basically the shift of the upper vertebra over the lower vertebra. So in between there is a disc. So this is the neutral position, let us say. So now whenever there is a shift, so this would be 25%, this would be 50%, this would be 75%, and this would be 75 to 100%. So 75 to 100% is completely surgical cases. Until 25 to 50, we can treat. Okay.
Thank you, sir. Thank you, sir.
Good evening, sir.
Dr. Rahul, may I ask?
Yes, ma'am.
Okay, when treating for local stimulation of the iliopsoas, we're inserting the 4 needles around that center point. Right.
No, this is iliopsoas and this is hamstring.
Oh, sorry, hamstring, yes. So when we're inserting the 4 needles, do we insert all 4 needles at one time?
All four.
Okay, so we hold one.
Hold one needle and stimulate other one. Hold one needle, stimulate other one.
Okay, thank you.
Good evening, sir.
Okay. One last question.
Good evening, sir.
Hello, sir.
Yes, ma'am.
So this treatment has helped to reverse the condition. This slipping the perpendicular.
Yeah, it will go straight.
Okay. Between the upper border and lower border of the disc, no?
Intervertebral disc. Yes, perfect.
Okay, sir. Thank you so much, sir. Thank you.
Thank you, all of you. And we'll take more questions.
Thank you, sir.